Good evening, everyone. I welcome you all for the day 2 of Eternal Heart Conclave, EHC 2020. My topic would be STEMI with cardiogenic shock, what physicians need to know. Cardiogenic shock is a common cause of mortality worldwide, and the management remains challenging despite advances in therapeutic options. And it is caused by severe impairment of myocardial performance that results in decreased cardiac output, end organ hyperperfusion, and hypoxia. Usually presents as hypotension, which is refractory to volume resuscitation, with features of end organ hyperperfusion requiring pharmacological or mechanical interventions. And the acute myocardial infarction contributes for 81% of patients with a cardiogenic shock. These are the various contemporary trials and the guidelines which look into the various criteria for diagnosing cardiogenic shock. There is a lack of uniformity. The shock and IBP shock 2 trials used systolic BP less than 90 millimeter of mercury for equal to more than 30 minutes, or use of pharmacological or mechanical support to maintain systolic BP of more than 90 millimeter of mercury. And the evidence of end organ hyperperfusion was determined by urine output less than 30 ml per hour, cool extremities, altered mental status, and the serum lactate more than 2 millimoles per liter. And the shock trial included cardiac index less than 2.2 liters per minute per meter square, and the pulmonary capillary wedge pressure more than 15 millimeter mercury. However, cardiogenic shock is a continuum that extends from the pre-shock to refractory shock, and thereby the timely consideration of various interventions are very important. The cardiogenic shock complicates 5 to 10% of cases of acute myocardial infarction, and it's a leading cause of death following MI. STEMI is associated with twofold increased risk for development of cardiogenic shock compared to non-acceleration MI, and the higher incidence of cardiogenic shock was observed in women, Asian Pacific Islanders, and patients over the age of 75 years. And in-hospital mortality is improved, but the 6 to 12 months mortality has remained unchanged at 50% over the last 2 decades. If you look into the pathophysiology, the reduction in myocardial contractility resulting in the diminished cardiac output, hypotension, systemic vasoconstriction, and the cardiac ischemia. And the hallmark is peripheral vasoconstriction and vital organ damage, which stems from ineffective cardiac output and insufficient circulatory compensation. Compensatory peripheral vasoconstriction may initially improve the coronary and peripheral perfusion. However, it contributes to the increased cardiac output load and that burdens already damaged myocardium. The systemic inflammation causes pathological vasodilatation, releasing nitric oxide synthase, peroxynitrite, interleukins, and TNF-alpha that contributes to the mortality in patients with a cardiogenic shock. The clinical presentation, physical examination, usually it's a classic ACS signs, symptoms and signs are combined with hypotension, altered mental status, diminished peripheral pulses, dyspnea, peripheral edema, jugular venous distension, and orthopnea. This is how we categorize predominant left side failure. If a patient has on the right side, patient will have a lung crickles, respiratory wheeze, displaced cardiac apex, and the left side heart murmur. If patient has a predominant right side failure, it will be lower limb edema, sacral edema, hepatomegaly, jugular venous distension, and the recurrent murmur in the tricuspid area. And if both the ventricles are involved, usually it's a shared finding. It's a cool peripheries, cyanosis, orthopnea, and delayed capillary refill. One should have an involvement of more than 40% of left ventricle to develop the cardiogenic shock. Patient should have an infarction of more than 40% of LV to result in the cardiogenic shock. And it can occur in the setting of acute infarction superimposed on previous old MI or a new massive myocardial infarction. These are 3 different types of presentation. The most common is cold and wet. When patient has a reduced cardiac index, increased systemic vascular resistance, and increased pulmonary capillary wedge pressure. Second one is a cold and dry, reduced cardiac index, increased SVR, and normal pulmonary capillary wedge pressure. Third one is wet and warm, which is having a bad prognosis, reduced cardiac index, low or normal systemic vascular resistance, and increased pulmonary capillary wedge pressure. Usually we see in the systemic inflammatory respiratory syndrome. Initial investigation, cardiac catheterization is the both definitive diagnostic investigation and guides the therapeutic intervention in cardiogenic shock complicating acute myocardial infarction. And One should remember, cardiogenic shock is a clinical diagnosis and no investigation should delay the emergent cardiac cath. The ECG, one of the basic investigations, should be done within 5 minutes of presentation. S3 segment elevation of equal to more than 2 contagious leads in an indication for urgent reperfusion. And pathological Q waves predicts lower ejection fraction large MI. And we can have any kind of arrhythmia, VT, VF, AF, new-onset LBB, high degree AV block. And other investigations, cardiac, blood counts, biochemistry, and serial troponin levels, blood gas analysis, lactate levels are very important in prognosticating the cardiac shock. And echo assessment of LV function, RV function, mechanical complication, like a ventricular rupture, MR, mitral regurgitation, free wall rupture. These are the important things which one has to look into while assessing the patient cardiac shock. Initial resuscitation, start with the loading with the antiplatelet or statin in the ER, then IV fluid resuscitation, and subsequently the IV vasopressors. The NORAD infusion is the commonest of all. And then you can have an ADR or vasopressin infusion and rush the patient to the cardiac cath lab without any delay. IV fluid, this is a clinical challenge in the early management. And echo assessment of right-sided heart volume status is very important. You can put an echo probe and determine the heart volume status. Right-heart cath remains the gold standard in assessment of the volume and should be performed in conjunction with the coronary angiography. And if hypovolemia is present, the conservative boluses of crystalloids, 250 to 500 ml, and while the patient is being stabilized for the cardiac cath. Continuous pulse oximetry should be used, and it depends on the underlying comorbid conditions like COPD or obesity. Saturation of more than 90% is reasonable, and non-invasive form of oxygenation ventilations are to begin with, but if it inadequate, then we have to go for the invasive ventilation. One should use a low tidal volume strategy in the when we go for the mechanical ventilation. When we go for the vasopressor support should be titrated to the target of mean arterial pressure of more than 65 mm of mercury. The commonest vasopressor to be used is a noradrenaline infusion, and the vasopressin has less pulmonary vasoconstriction than norepinephrine, and the more beneficial in patient with cardiac shock with the predominant right-sided failure. And pulmonary vasoreactivity can be modified by the inodilator, phosphodiesterase 2,3 inhibitor, or nitric oxide. And whenever we have a vasopressor support, high support, one should go for the invasive monitoring. These are the different vasopressors. The commonest one to be used is norepinephrine infusion, and the second one as second line agent is epinephrine, dopamine, or vasopressin. Vasopressin, especially when patients having a or RV dysfunction, then vasopressin is preferred. Dobutamine, levosimendan. Continuous renal replacement therapy or CRRT. AKI occurs in 13 to 28% patients with a cardiac shock, and 20% patients requires continuous renal replacement therapy. And CRRT should be considered with a stage 2 kidney injury as defined by serum creatinine more than 2 times from the baseline and the urine output less than 0.5 ml per kg per hour for more than 12 hours. And CRRT is also required when there is a life-threatening changes in the fluid, electrolyte, and acid-base balance. Humanoid monitoring is very important in managing cardiac shock. The basic parameters which we usually monitor is a continuous BP monitoring by arterial line, telemetry, continuous pulse oximetry, respiratory rate, and urine output. The important parameters we observe by the mixed venous oxygen, SVO2, by drawn sample from the distal port of the pulmonary artery catheter. Low SVO2 is usually seen in the reduced cardiac output. Other causes are anemia, hypoxemia, and increased O2 consumption. So SVO2 is a very important parameter. Humanoid monitoring by pulmonary arterial catheter placement is typically is done during cardiac cath. It assists in the identification of patients requiring mechanical circulatory support, and the continuous hemodynamic monitoring helps in assessing the fluid status, SVO2 measurements, response to therapy, and indicates the effectiveness of mechanical circulatory support. Hemodynamic monitoring by pulmonary artery catheter is gone into controversy. There's a large meta-analysis which showed that it does not confer any mortality benefit, does not reduce the length of ICU and hospital stay, and its use in critically ill patients shown to increase mortality, and there are various complications also associated with this. So it has gone out of favor. used in only justified in a few cases in whom we really think clinically indicated. Mechanical circulatory support is very important for the management of cardiogenic shock. As we go for the high catecholamine therapy, it results in an increased myocardial oxygen consumption, thereby it results in cardiac arrhythmias, and inadequate circulatory support eventually leads to high mortality. Just to overcome this limitation of catecholamine therapy, mechanical circulatory support is very important. Early MCS device, early mechanical circulatory support improves the survival. MCS we have is IABP, intrauterine balloon pump, time tested for last 4 decades. Impella 2.5, Impella CP, and Impella 5. Other are ECMO and tandem heart. This is the summary of various MCS devices. IBP Shock 2 for the IBP versus optimal medical therapy in shock patients. The PROTECT 2 trials for the compared IBP and Impella. I'll be discussing one by one in the next few slides. This is the pressure volume curve, and the patient with cardiogenic shock use IBP, it reduces the systolic pressure, increases stroke volume, and thereby decreases cardiac work. Use the Impella, it decreases, it unloads the left ventricle, decreases the pressure volume loop area, thereby decreases the cardiac load. Intrauterine balloon pump, most common support device used in cardiogenic shock worldwide. It has been used for more than 4 decades, and it decreases cardiac load, afterload, decreases myocardial oxygen consumption, improves the coronary perfusion, and modestly increases the cardiac output by 8.8 to 1 liter per minute. IBP Shock trial, Shock 2 trial was negative. 600 patients with cardiac shock from AMI receiving early revascularization, randomized to IBP versus optimal medical therapy. And there was no mortality benefit in between the IBP and optimal medical therapy at 30 days. And follow-up at 6 and 12 months, no reduction in all-cause mortality or improvement in the quality of life assessment. And the limitation of this trial was the IBP insertion occurred within 24 hours, before and after. So if you put an IBP a little later, there are no benefit. And 30 crossovers, sick patients were crossover from medical arm to the IBP arm. And culprit versus multivessel PCI was determined by the operator. These are the few limitations of IBP Shock 2. The other important device which is come into picture in the last few years is Impella. Impella is the axial flow pump, advanced from the common femoral artery and passed retrograde across the aortic valve into the left ventricle, and this ejects blood from left ventricle into ascending aorta. And Impella 2.5 and Impella CP devices are commonly used, and it maintains cardiac output 2.5 to 4 liters. Impella 5 maintains the cardiac output 5 liters. It requires a bigger sheath, and that's why it required a cut down. In contrast to IBP, Impella acts independent of heart function and the cardiac rhythm. And left foot PVL shift and decreases in pressure volume area, thereby decreasing myocardial oxygen consumption. This is how it looks like. It goes from the femoral artery to aorta and then across the aortic valve into the left ventricle, and it sucks the blood from the left ventricle and ejects into the aorta, thereby maintains the cardiac output. Impella has demonstrated greater intraventricular hemodynamic stability and is the most optimal therapy for management of cardiac shock. There are various trials which looks into the role of the Impella. One is the PROTECT 2, in which the complex triple vessel left main disease and severe dysfunction who required a non-emergent or elective PCI were randomized to Impella versus IBP, and MACE at 30 days were not statistically different between the two groups, but MACE at 90 days was less in Impella group. But the PROTECT trial did not include the patient with cardiac shock. And this is one of the trial, IMPRESS, Impella versus IBP in STEMI with the cardiac shock, treated with the primary PCI. There were no significant mortality benefit at 30 days, the 50% mortality in both the groups. A limitation of study was small sample size, and this trial supported prior finding of increased bleeding risk with Impella. And we know the shock, IBP Shock 2 and IMPRESS all showed 50% mortality over 6 to 12 months, and the constant mortality outcomes in cardiac shock over past 2 decades, despite widespread use of mechanical circulatory support. Impella in cardiac shock, new insights by the various registries which we got recently. The CVAD registry, catheter-based ventricular assist device, this early MCS implantation cardiac shock before starting inotropes, vasopressor support, and before PCI is independently associated with improved survival. If you put a device early in the course of a shock, then it's really going to make a big difference in the improvement of survival. Detroit Cardiogenic Shock Initiative, there was a pilot study and reported 76% survival to discharge with this approach of early MCS. And Detroit Cardiogenic Shock Initiative eventually results in the National Cardiogenic Shock Initiative, which is going on. It's going to finish in May 2022, and then we'll be doing a great data with us. And the Tandem Heart is one of the device which connects from LA to arterial MCS device. An atrial septal puncture is performed to assess the oxygenated LA blood, and which is aspirated and pumped into two of the femoral arteries. It unloads LV and decreases pulmonary capillary wedge pressure and LV and diastolic pressure. Limitation is its requirement for specialized skill set that includes a transseptal puncture and time for to unloading. ECMO is a veno-arterial ECMO, involves the drainage of venous blood and passing through the oxygenator and returning oxygenated blood back into systemic circulation by using a centrifugal pump. Centrally, it requires the cannulation of right atrium and aorta, and peripherally cannulation of femoral artery, femoral vein. And peripheral ECMO reduces the cardiac preload, but might increase in the afterload, hence need for the close monitoring and LALM unloading. It is usually used as a bridge to recovery, bridge to LVAD, or emergency cardiac transplant. Coronary angiography is the most important investigation which we perform in patient cardiac shock, and it enables the patient to identify the precise location of lesion that precipitated the cardiac shock. And usually 15 to 20% patients have an left disease, and more than 50% patients have a peripheral muscle disease. And after evaluation of coronary anatomy, patients usually go for the primary PCI. PCI strategy for STEMI with cardiac shock. Coronary reperfusion is an essential therapeutic intervention, and the shock trial clearly advocated that if you go for the primary PCI versus medical therapy, the 6-month mortality is significantly less in the PCI group, 50.3 in PCI and 63 in a medical therapy. So medical therapy versus PCI is better in cardiac shock. And if you look into the complete versus culprit vessel PCI and STEMI with cardiac shock, the culprit shock trial evaluated culprit lesion PCI versus multivessel PCI. 706 patients randomized, and composite primary endpoint was death and renal failure requiring dialysis at 30 days. There was a 9.5% absolute risk reduction of the primary endpoint in culprit lesion PCI, and a 7.3% absolute risk reduction in all-cause mortality. The limitation of this trial was greater diload in multivessel PCI, more complex and comorbid patients in the multivessel PCI group, and the low rate of MCS device use. Another major registry was CAMIR NIH registry, which looked into the complete versus culprit vessel PCI. This was Korean registry, Korean Acute MI, National Institute of Health registry. Multi-center prospective registry randomized or involved 659 patients. The all-cause death at 1 year was 21% multivessel PCI versus 31.7 in a culprit vessel PCI. It was significantly less in multivessel PCI group as compared to culprit vessel. And the composite outcome of all-cause death, MI, and repeat evasc was also significantly less, 28% multivessel PCI compared to the 42% culprit vessel PCI. So there was a discrepancy between the two trials, culprit vessel PCI and the CAMIR NIH registry. So we need a larger trials that stratify according to the door to LV unloading in tandem with the randomization to culprit lesion versus multivessel PCI to resolve the discrepancy between the culprit shock and the CAMIR NIH registry. And this is one of the patients, 53 years old patients who came with a history of chest discomfort, perspiration, and syncope. And he was found in complete heart block, put in TPI, underwent angiography, found to have a RC 100% proximal to mid and the LED 99%. He was put on a impella support and underwent PCI for the RCA and the LED in the same setting, and he was discharged day 3 here. So the final take-home message is, despite significant advances in infarct management, persistent high mortality has been observed in cardiac shock over the past 2 decades. A new approach that emphasizes on rapid LV unloading and prompt coronary revascularization may reduce mortality of this devastating complication of AMI. Thank you.